So thank you everyone for joining us today. This is the third Conscientious Care Conversation that we are hosting at Tannenbaum Center for Interreligious Understanding. We are joined today by three distinguished speakers, and they are going to be discussing how religious communities have been impacted by COVID-19. So just to give you a little bit of background on our speakers today, we are joined by Dr. Richard Semino. He's a lecturer in sociology at SUNY Old Westbury and founding editor of Religion Watch, a monthly publication reporting on research and trends in contemporary religion. He is currently conducting research on ethnic and religious diversity in Queens, New York. We are also joined by Rabbi Julie Schoenfeld. She is the former CEO of International Rabbinical Assembly and founder and CEO of Leading Ethics LLC. A pioneering woman in religious leadership, Rabbi Schoenfeld began her career as a rabbi of the historic synagogue, the Society for Advancement Judaism in New York City. Rabbi Schoenfeld served as CEO of the Rabbinical Assembly, the International Association of Conservative Rabbis from 2009 to 2019, and is a recognized spokesperson for the Jewish community. And finally, we are joined by Pastor Hottinger, Pastor David Hottinger. He's a native of Marion, Ohio. David graduated from Oberlin College and Harvard Divinity School. He is a Raul, did I pronounce that correctly? Wallenberg. Awesome. Fellow at the Hebrew University of Jerusalem and served with a non-governmental organization working with Palestinian refugees in the West Bank and Gaza. David has over 20 years experience as a chaplain in a war zone, acute mental health care, level trauma centers, hospice, and community care settings. He is transitioning from his role as manager of spiritual care at Hennepin Healthcare, a level 1 trauma center, Safety Net Hospital in urban Minneapolis, to become the director of spiritual care at Presbyterian Healthcare Services in Albuquerque, New Mexico. So thank you so much for joining us today, everyone. Okay, so if we are all ready to start, I will just dive into the discussion questions. So can you each tell us a little bit about your background and the work that you do? Dr. Semino, would you like to go first?
All right. So thank you for inviting me. So I'm a sociologist and also a journalist. And so I've looked at COVID and its effect on congregations in both ways through reporting on a lot of the new research that's been conducted about churches and other congregations and how they're affected by COVID and what impact it's had on their ministries. But also in this work on doing in Queens, where I've looked at congregations. And interestingly, we started right before, like a year before the pandemic. And then we continued until the pandemic happened, a little bit after, about a month after. And then we started up in the spring of 2021. So we have kind of a bird's eye view of what's been happening with congregations, on the ground. And I am conducting this research with Hans Tuck, who's a professor at CUNY City Tech University. Okay.
Thank you so much. And Pastor David Hottinger, would you like to go next? Tell us a little bit about your background and the work that you do.
Yeah, sure. So I will be speaking mainly from my experience at Hennepin County Medical Center. We're a level 1 trauma center in downtown Minneapolis. Also, importantly, a safety net hospital. So we serve a very diverse patient base, including one of the largest East African immigrant communities in the United States, primarily from Somalia. And so I oversee, I'm just transitioned. So last week I left Minneapolis. I'm starting this new role in Albuquerque. So I'm going to have a hard time with past tense versus present tense. In my role, though, in Minneapolis, I oversaw a team of 14 chaplains who included those who would identify themselves as interfaith chaplains. So the expectation of professional chaplains is they meet people where they are spiritually and religiously, and then either connect people to explicitly religious resources and leaders, or address spiritual needs in a kind of more general way that may or may not involve religious practice or tradition. We also have 2 full-time East African Somali faith providers. And I'll talk a little bit more about that. Actually, initiative just happened this past year, the height of COVID, and is really kind of breaking some new ground to have explicitly Muslim spiritual care. Many hospitals throughout the United States have not done that yet, and that became really crucial for us at the height of the pandemic, because our East African community was very much disproportionately affected by COVID-19. Also oversee some folks who come from the Archdiocese of St. Paul in Minneapolis, including a couple of priests, and then coordinate religiously with religious leaders throughout Minneapolis, St. Paul, particularly from, I would say, Jewish community services, as well as some other large faith communities. So my role the last 2 years was very much involved in caring for patients who came in with COVID-19, their families. And then our hospital is a hospital where George Floyd died. So I can't really separate out my thinking and processing COVID-19 from the other pandemic, which is systemic racism in the United States. And that had a huge impact on our healthcare system and many of our religious communities in Minnesota.
Absolutely. Thank you for sharing. And Rabbi Julie Schoenfeld, I'm sorry, I know I cut your bio a little bit short, so I will let you talk about your work and your experience in your own words.
No, I was so glad you did. I was going to send to you in the chat. Don't say it's not necessary. So thank you so much. Pleasure to be here with everybody. As you mentioned, I am the former CEO of the International Rabbinical Assembly, which is an association of faith leaders working in 26 countries across all of the spectrum of Jewish life, synagogues, hospitals, universities, organizations, etc. And since then, I do work as a consultant on matters of organizations. And this past January, I received my master's in public health from the City University of New York. And so to kind of attach my work to what we're talking about here, I think for purposes of our conversation, best to focus on 3 areas. One is because much of my career has been involved in forming partnerships and coalitions on interfaith and intergroup matters, working with government and business and civil society interlocutors. I got very involved in this issue during the COVID-19 pandemic of trying to help the public health sector and the government sector focused on public health to interact most productively with the faith sector and hopefully bring the resources of the faith sector to bear on helping our society to cope with the pandemic and to overcome the pandemic. The 2 areas in public health research in which I focus, one is on the shortage of mental health care, which of course has become much more acute during the pandemic, and looking at ways especially that the faith community can mobilize its resources to help people, at least in a baseline of mental health and mental wellness, as well as escorting and accompanying people and serving as a resource to the mental health treatment community, but especially helping people just to use their communities in a way that's strengthening. And also a focus on ensuring that our seniors and elderly continue to get the care that they need and are helped in the isolation and the additional challenges that the pandemic has brought on, which also include, of course, tremendous workforce shortages in people who help and work with the elderly, and very difficult circumstances that the elderly faced, especially those who were in congregate living facilities. So thank you. It's wonderful to be here.
Thank you so much for sharing, and congratulations on your master's degree. To give you a little background on myself, my name is Maria McQuaid. I am the Assistant Director of the Healthcare Program at Tannenbaum Center for Interreligious Understanding.
There you go.
To give you a little bit of background on Tannenbaum, Tannenbaum is a secular nonprofit dedicating to promoting understanding and building respect around religious diversity. So Tannenbaum imagines a world that respects difference and is committed to making that vision a reality. In the healthcare program, that means respecting patients' beliefs and practices as it relates to their care. Therefore, the healthcare program's mission is that patients of all religious beliefs and none receive religio-culturally competent care. Okay, and now we can move on to the discussion questions and kind of the meat of our discussion today. From each of your different experiences and perspectives and based on the work that you do, how have you observed religious life being affected by COVID-19?
I guess I could start. I usually don't like to jump right in. I just have 3 points I would make about my observations about religious life in my setting being affected by COVID-19. And I took a few notes here. Again, I think for us in Minnesota, and this was true in other parts of the country from what I have read, COVID-19 in the first 6 to 9 months disproportionately affected some of our most vulnerable communities. As I mentioned, we have a large East African community in Minneapolis, most of whom identify as Muslim. And in the first, I'd say 6 months of my experience in my hospital, many of our COVID-19 or very sick COVID-19 patients were Somali, followed by African-American patients, American Indian, Native American patients, of which Minnesota has a fairly significant population, particularly in our urban area, and then Latinx. And so those communities have historically very strong religious and spiritual traditions and cultures that very much come into play, especially in end-of-life situations or various kinds of health crises. So in my role as a leader of our spiritual care department, worked a lot with leaders from those communities as we navigated this incredible devastation, a lot of which was extremely complicated by the fact that, particularly I would say in the first 3 to 6 months, when there was so much that we did not know about the transmission of COVID-19. So hospitals went to these very draconian visitation policies. In the first couple of months, we weren't allowing any visitors into the hospital. And so as you might think about some of those communities I just mentioned, people feeling very much part of larger extended networks and clans of people who come together, particularly in times of transition and crisis, were then we did not have space for them to come into the hospitals. We cut off a very important source of connection and meaning and ritual for many of our patients and families, and that was really hard to navigate as a chaplain and as a team, and I would say as a healthcare system. We began to experience a lot of dissatisfaction in the community. Leaders coming to us and saying, this isn't acceptable what's happening. Yes, we understand there are health reasons why you might want to batten down the hatches, but recognize that there is also a great cost from a spiritual, cultural, emotional perspective, and you need to take that into account in your decision making. So I was part of a lot of conversations about opening up, visitation policy and facilitating more space on our campus for communities to gather. Alongside that was the murder of George Floyd, which happened just a few months for us into the pandemic. And that really shone the spotlight in Minnesota, at least for white Minnesotans, on the great disparities in healthcare. If you're white in Minnesota, your health outcomes are pretty darn good. If you are Black or brown, especially if you're African American, East African, your health outcomes are some of the worst in the United States, along with other sorts of social determinants of health. And so from a lot of the religious communities became very engaged in these broader conversations about why these disparities exist and how systems of care can begin to address them in a more meaningful way than they had historically. And then with that, I would say as a chaplain, I actually felt at a relative, had some gifts going in because I had started with my team, with some other people in our system, with some very extensive work, probably 3 years ago on trauma-informed care. Actually, fast forward 2017, so it would have been 5 years ago. We began a sort of system-wide transformation, looking at the impact of trauma on different populations, not the big T traumas, as in gunshots and car accidents, things that level 1 trauma centers deal with, but historical trauma, cultural trauma, intergenerational trauma that's induced by systems of care, particularly on communities that might be very vulnerable. And so that gave us a leg up, I would say, in some of the ways that we were able to frame the distress that many of our religious communities were experiencing. And by the same token, being able to identify sources of strength and resilience and incredible healing resources that many of our religious and cultural communities in the Twin Cities had. So my role really at the system level had there was a lot of interaction with religious cultural leaders in tandem then with our healthcare personnel. And my final point, for me, one theme that became really pressing, and I would say I left with an unresolved set of questions, and I'm taking into my new setting, how we help healthcare providers and others and family members who have experienced this incredible grief and sense of loss these past years deal with their own moral injury. It's a kind of suffering that occurs at the soul level when you're in situations that, when resources are scarce, people are asked to do things that are way above and beyond, or might be in conflict with their own deepest values. For example, the restrictions we put on visitors and family members during these really horrible situations. The moral injury then that was imposed on staff people who pretty much had to become the surrogate family members and loved ones for dying patients. We're at the bedside with an iPad, connecting family members with their loved one in their last hours and minutes of life. Doctors and nurses, even I would say chaplains, did not get trained to do that sort of thing. And there was a deep cost to it, which I think we're still grappling with. And so I found that really that language of moral injury, even though it comes out of psychiatry a little bit, especially post-Vietnam War and some research that was done on what was happening with veterans, religious and spiritual communities have a special, I think, depth of knowledge and resource in addressing these things that our psychology, psychiatry, medical colleagues do not. And so finding ways to really tap into that, I don't think I went as deeply into it as I wish I had, and that's something I'm hoping to do some more work on. So with that, I'll conclude kind of my remarks. Thank you.
Okay, thank you so much for sharing. And you bring up a lot of different interesting points that I think we can touch on later in the discussion. And specifically, I would like to dig into the topic on grief and loss and how COVID has impacted the different processes that we go through around these things. So like I said, we can dig into that a little bit more in the conversation. Dr. Cimino, if it's okay with you, I'd love to kind of pass the conversation over to you so you can talk a little bit about the work that you've been doing in Queens, what you've been observing in the religious communities there, and also how people have been impacted by the different legislative and lifestyle changes that have occurred because of COVID-19.
Okay, and I think what I have, the research I've done and we've done really in Queens, reflects national trends also. So I can kind of go back and forth and mention some national dynamics and developments that have taken place. But like I mentioned, when the pandemic broke, we were just kind of just finishing up the first phase of the research, and we noticed, obviously, most of the religious institutions closed, and especially because this was Elmhurst, Queens. And so this was seen as the epicenter of the pandemic in New York City, and New York was the epicenter in those early months of the country. So, it was a really serious, serious crisis that developed in the neighborhood where the hospital was seeing, the most incoming patients, and just, really terrible outcomes in those first few months, where there was no room for funerals. And I think, there were images of these trailers where they were keeping bodies, and, really, gruesome details about the pandemic. So the churches, and other congregations shut down, but we saw kind of an interesting development of how their social services and social outreach continued, and in some cases even grew in the neighborhood. And so, just for instance, the Jain Temple, which was, closed down longer than any of the other congregations, had a very strong ministry to the hospital, where they prepared lunches for the medical workers, and just very active in the neighborhood, as well as other congregations. And so that was an interesting trend that we saw, where there was this, continued social outreach. And, there was the fact that members, didn't have that vital interaction that they get from being part of a congregation. But it's kind of interesting that the religious leaders, even if they couldn't go to the hospital rooms, did have more of a feeling of interaction and involvement during the pandemic. And we see a lot of this reflected nationwide. So I often refer to a new study that's being conducted called "The Pandemic's Impact on Congregations" by Hartford Institute for Religious Research. And so they found also that 70%. So this was conducted among 1,000 congregation leaders, and they found that 70% agreed or strongly agreed that they engaged in social service programs, during the pandemic. So that's, an interesting development, how that remained during this time. And then we started up our research again in the spring of 2021. And this is where we saw different patterns emerging. So the Catholic Church, because of its strongly, sacramental practices with communion, they had opened up before the other congregations, following mandates as far as masking, social distancing, but still they opened up earlier. Then we found the evangelical churches that were more outreach oriented also opened up a little after the Catholic churches. And then more of the non-Christian and mainline churches opened up later. And all of them, maybe aside from the Catholic Church, had hybrid ministries where there was some online presence still, while there was opening up of certain ministries. So Bible study might continue to be online, while the worship service would be open with, following the health precautions. So that's been the patterns, we've been finding, in Queens as we've gone forward, as well as throughout the country as I've looked at the research. This pattern of, moving to a hybrid type of worship service, and, bringing back that interactive element that congregations, see as so important. And, but definitely we see different levels of health, public health precautions. So you still would see social distancing, masking, especially with Omicron. That was revived in most churches. But then you would see other practices that maybe communion going back to normal or how it was, but then other churches where they would still practice communion at home. And that's, a sticky issue since some churches, the Catholic, Episcopal, Lutheran, tended to, if they didn't have the service of the communion in person, they would, have a substitute for that, such as spiritual communion or something that, didn't change their own practices, relating to doctrine about communion. And so, so that's what I'm seeing now, different practices coming about. I just was at a church where they're talking about Ash Wednesday, and they're providing ashes in packets to members, where they're sending it to members, these packets of ashes where people can administer them, to themselves and or to family members. And so definitely, new practices coming about. And I would say I can get into this later, probably the digital element and the hybrid services, I think are the way we're really going to see a lot of changes. There's definitely declines in people coming back. So the Hartford research project found that 15% of congregations who reported only meeting in smaller congregations experienced decline. And so then those that met in person experienced the sharpest levels of decline. And so that was of 15.7%. And then those that were completely online, the decline was, I should correct myself, 7.3%. And then those congregations that were hybrid experienced the least amount of decline, and actually showed some growth, which was interesting. 4.5% showed growth of hybrid services where, I'm having both online and in person. So these are just kind of, my, preliminary observations, but also, citing other research that's just being conducted now. And so, I would say, and as I mentioned, it's, definitely a topic everyone is going to want to speak about, this way that people, is there less interaction? Are people less involved personally, face to face, when these, hybrid forms of worship develop and, increase?
Absolutely. Thank you for sharing. And I have to say, I think we're all still trying to navigate our way through this pandemic. And kind of as new variants come out, and we're trying to find ways to kind of maintain community and closeness with other people. It's nice to see that religious communities are getting creative with different ways to kind of maintain that intimacy that religious communities really need. Rabbi Schoenfeld, would you be able to talk a little bit about what you're seeing kind of at the denominational level, what observations you've made?
Sure. Thank you. So, one of the things that was very interesting to me during this period of time, because so much of my career has been about denominational, convenings, multi-sectoral convenings, multi-faith work, intergroup work. That was sort of the first place where I went in March of 2020 at the start of the pandemic. And not surprisingly, I was joined there by all the other people who, kind of did that kind of work and had the same feeling that that the sort of the denominational groups, wherever people can sort of network among a lot of different congregations in a lot of places, that we would be able to bring a lot of value to helping people during the pandemic. And one of the things that was a real eye-opener for me was to learn sort of in what sectors of the public health and health-related world people were thinking along these lines, and in what places this was really a time of discovery for them. And I feel like it was a time of tremendous growth in this way. I hope that we can keep a lot of these conversations going. So there were a lot of people from the faith world who started to lobby, I would say, the federal government, HHS, their state level agencies, state government, wanting to see churches and houses of worship as potential places for vaccine distribution, and to help public health officials and government officials sort of appreciate their potential as trusted messengers and as places where people in the community are used to gathering. Reverend Hottinger, I really hear you on, social determinants of health. And our faith communities are places where, a lot of our communities and faith leaders do a tremendous amount of work in the community to try to address social determinants of health. And so over time, but in places like, for example, public health centers in academic universities, in major medical centers, you don't necessarily find the same level of integration of the faith sector with the public health sector. And I think that one of the sort of gains that we will hopefully make if we can keep it going in the aftermath, God willing that we should get to an aftermath decisively of COVID, is that more of these people met each other, right? More of the people who, work in state level and national level networks and associations of public health officials were able to sort of get to know a lot of faith-based groups and really understand, especially on issues, let's say, take, for example, vaccine hesitancy or testing or, public information, to really kind of recognize the tremendous impact that the faith sector has and how it reaches people, in every town, city, hamlet in our nation. So I think that was very powerful. And I think it's something, by the way, that's well understood by elected officials, because when they go out in an election, they reach out and they're looking for places, who are people who are big connectors. So that's, I think, something that that we learned a lot from. Obviously, elected officials can't speak from not-for-profit organizations, but they're appreciating kind of the influence of the faith sector. Then I want to say a little bit of building upon these questions of how faith and digital have intersected and what that's going to mean going forward. And Dr. Cimino, I know, has a lot of really interesting research and insights into kind of hybrid and, when people were able to, go back, how people are still struggling with going back to their house of worship. And I want to make a couple of observations. One of the things that happens when things are going so-called normally is that we forget all the people for whom normal isn't working. So while in a lot of ways, a lot of people felt, well, it's true, right, that when we do digital worship, we lose a tremendous amount. There's a lot of people, the elderly and disabled, who aren't being reached by our houses of worship, who can't get there, who can't, walk up the steps of the building. And so a lot of people who weren't previously reached were able to be reached, as well as people, by the way, who are not, for example, neurotypical. And so for whom having that kind of digital interface might have made it more possible for them to interact with the faith community in a way that they could personalize and tailor more to themselves. But the whole digital question, and I believe it's very much a question. So we see, for example, telemedicine, right? Telemedicine jumped ahead by leaps and bounds that were almost unimaginable before the pandemic. And people now view doctor visits in many, many areas as being doable digitally. So the question is, how much is faith community, worship, is it or is it not, or to what extent is it, in what ways is it something that has a good sort of intersection with the digital. And I think it's kind of a both and. And another thing I'll call attention to is that, a lot of faith communities during this time, it was very, as with a lot of things in our society, very unevenly distributed in terms of which communities had a lot of capacity to do very, fancy digital work and bring in a lot of cameras and, go into their sanctuary and project services, and small communities, which actually make up the majority of American houses of worship, that really didn't have those resources. So another impact in the faith sector that COVID brought about was, as with so many things, it increased those differences between the sort of haves and the have-nots, if you will. And the whole tech industry has been about sort of favoring bigness, big companies. And one of the things we have to really pay a lot of attention to as we, God willing, again, emerge from the pandemic is that we don't see that same kind of bigness in technology then layered onto houses of worship, so that smaller communities are less able to be vibrant and to flourish and to sustain themselves. And then the very last observation I'll make is, again, this issue of mental health, which was a part of my research during the pandemic. And really recognizing, it's almost, we can't say it enough, how these mental health sequelae of the loneliness and isolation of the pandemic, what Reverend Hottinger was referring to, and is a very tangible public health issue. Our society, because of the deep stigma around mental health, tends to view the electrical, chemical, and physical impulses that go in and out of every other organ in your body as okay to talk about because that's physical health, but the electrical, electrochemical, and physical impulses that go into your brain somehow get into this area that, God forbid, people should be able to talk about it openly. And there's tremendous stigma and tremendous suffering, which was very much exacerbated by the isolation of the pandemic. And it's one of the top issues that we have to address. So those are my thoughts.
Thank you so much for sharing. I think you bring up a lot of really good points that we can talk about. I do want to give Reverend Hottinger the opportunity to respond to a question that we were asked by one of the participants in the webinar. I know you responded in the chat, but just in case there was anything you wanted to share with the group, and also give the other panelists an opportunity to respond as well. The question is, do you believe there is a difference between trauma-informed care and service delivery and religio-culturally competent trauma-informed care and service delivery?
Yeah, it's a great question. As I mentioned in the chat there, in theory, cultural humility is a principle that's built into trauma-informed care. So it kind of moves beyond cultural competence, recognizing there's a limit to how competent we can be in someone else's culture, let alone our own. But a baseline knowledge, particularly in healthcare, is important. But I love the question because there are nuances here, I think, with religious, cultural, spiritual identity, which often do not get highlighted in trauma-informed care as a discipline. I think that's growing, particularly voices from, and like I mentioned in the chat, I started teaching a course at a mainline seminary last summer on trauma-informed care through a spiritual care lens. And we used material. There's some amazing stuff coming out from some of our Native American leaders, as well as Resmaa Menakem, who's actually based out of Minneapolis, who wrote My Grandmother's Hands. And he really talks about the importance of white people in America getting in touch a lot more with the cultural and ancestral roots of our own trauma, particularly as it has become racialized and then has an impact negatively on communities of color. So there's a lot of work to be done there. And I find it really an interesting time because communities, one thing I didn't get to mention, the spiritual questioning I've encountered in the past 2 years among my peers in healthcare. So not chaplains, but nurses, doctors, social workers. As you might imagine, in the height of a crisis, there's the questioning, and some of that has been excruciatingly painful for people. Where, how could a benevolent God, allow this kind of thing to happen? The theodicy questions. Some of it's had to do, I think, with what Julie has mentioned a little bit too, with grief and loss and social connection. And when people are feeling that those connections have broken down, it does raise a lot of existential sorts of issues for people. And I've had conversations with colleagues in the last couple of years that I never had before. People just seeming very open. Okay, now what? But a big part of that, it is making space for the pain. And I don't think systems have done a very good job of doing that. And I think that's where secular systems like healthcare institutions, educational systems, probably have a lot to learn from faith communities about how to create space for grief and loss and mourning, to have a container. So as people bring in that sense of like, what's happened here and why is this happening? If there's not a mechanism to do that, it comes out in all kinds of other strange ways that aren't very healthy many times in my experience. And we had a hard time, believe it or not, in my own healthcare system, we had a very hard time getting our leaders, love all of my leaders, but when we said, we need to stop and look at what's happening, take a step back and grieve. And this was not met with widespread acceptance among leadership, because leaders of systems like to solve problems and move on and put things into their algorithms, and this did not fit the script. And then some of our leaders said, well, if we do that, we also need to tell the positive stories about all the people we've saved. And we said, that's not how the workers are feeling. They want to stop and ritualize the grief here. So we turned to some of our own religious and spiritual leaders in the community to help us put some things together to do that. But it was a bit of an uphill battle in our system.
I just want to add one, or just, I will just say actually amplify Reverend Hottinger, one of your points, which is, the fact that our country has lost almost 1 million Americans, and across all faith or not, people of faith or no faith, right? We are all spiritual human beings of infinite worth. The just way in which our country has really not grappled with that meaningfully.
Yeah, and I wonder, is it why do you think, Rabbi Schoenfeld, do you have any sense of what that might be about our system, why we've had a hard time doing that?
Well, there's been, our country has also, relative to other countries of similar standards of living, has done very poorly overall, right? We've really done very poorly overall. It's a good question, and it's in some ways one of the most, with all the many, many troubling things that we're all grappling with these days. In some ways, it's one of the most troubling, right? The fact that 1 million Americans, right, lives have been lost, more than I believe all of our foreign wars combined, and we're really not coping with it. I think that some of it is because it happened in this isolation. My own theory, I'm very interested in the ways in which the digital environment and the digital environment's interest in monetizing our attention, right? And in many ways, in doing exactly the opposite of what every faith community has done since the beginning of time. We have all dedicated ourselves, knowing what human limitations are, to helping people calm and achieve some kind of equilibrium amidst those limitations. And of course, because people have monetized high emotions, these digital tools actually go and do exactly the opposite. They try to ratchet our emotions so that they can monetize our attention. And so when we talk about, to me, things like polarization, isolation, these are sequelae of that core issue, I believe. And so Reverend, that's where I would point to it, right? I believe that we're living almost in this time where we're all walking around with these very battered, damaged brains that can't keep up with the kind of inputs that we're facing. And so a lot of things, to sort of paraphrase something you just said that I liked, if it doesn't come out in a sort of a kind of a thoughtful way, it comes out in all kinds of other ways. And I sort of think that's where we are on this. And that's part of why we haven't been able to come to some communal grief, even though it's so obvious and it's touched so many of us. It's touched all of us.
So this kind of actually brings me to my next question. And I know you've already talked about this a little bit, but in what ways have you seen religion help people to cope with grief and loss and this kind of unique experience of grief and loss? And how have you seen religious communities respond to this kind of this situation we're in this this very new experience of how we're dealing with grief and loss?
I have just seen, from my research in Queens, how there is an attempt to, memorialize people that have passed away. And, most of the churches and congregations have had some type of memorial, services, people who are, just gathering people together online or in person. And I think, I think it's going to happen gradually, but it is true, we really haven't seen, at least on a national level, a kind of a mourning type of process take place. And I just, I think it'll come gradually, but, and maybe a lot of it won't be online since there is, the Zoom fatigue that's happening. And, is it the best place to always do that type of, in-depth emotions, online? And, from my experience, just teaching online, it's been, a touch and go and not, always the best place for learning and interaction. And so that's why I think, most congregations are learning this, hybrid model. And, and we'll try to convince more people to meet in person. But as I think Julie mentioned, how is just, it is reaching people who haven't been able to go to services even before the pandemic. And so that's going to be a vital part of ministry. So there's an interesting quote here that I had from a Baptist minister in Queens, where he's talking about how the camera, how the church will continue to have online services. And then he says, we're going to come to see the camera as a door where people enter the church. It's the way that the visual meaning of this instrument will become part of the church, the way that the screen is a holy object. And we have to come to terms with this. And so I think that, is going to be something that happens where it just becomes part of a congregation's service. And, the interaction is important, but also that element of reaching people who aren't, who aren't able to come to services. But I'm kind of getting a little bit off the track. I'll defer it to the other participants about your question. Thanks.
If I can just say briefly, yeah, and I affirm all those things, and I'm grateful for the religious communities that have explicitly addressed COVID, mourn those who have died. I also think, from my perspective, some of our religious communities have also been complicit in the denial in some ways of this reality of mass death and suffering. And so that, in spiritual care and psychology, there's a term disenfranchised grief. So it's grief that is stigmatized. Suicide used to be one of those kinds of grief and still is in some communities. In some communities that I've observed in Minnesota, at least, COVID deaths were somewhat disenfranchised in terms of grief. And so there was a reluctance to put in the obituary anything about the cause of death. Religious services weren't alluding to it when someone was able to have a funeral. And I think it's one of the things religious communities ought to take on, like we have with suicide. My brother actually died of suicide just 6 months into COVID. Part of it was his mental health had been challenging for many years, but COVID was a very significant factor in the social isolation contributing to his suicide. And I was grateful that my family chose to be very open about the cause of his death. And we got so many affirmations from people in our largely Appalachian community in Ohio said, oh, we're not used to having people talk openly about this, and particularly in a religious setting. And I think with COVID-19, there's also an opportunity that I would like our communities to take on more.
I'll just add, so in the Jewish community, the rituals of Shiva, the Jewish community has a very sort of guided, focused way of taking people through the process of grief. And all of those rituals were interrupted. And so many people, most people actually, who lost a loved one, whether because of COVID or not because of COVID, during this period of time, didn't get to sit Shiva. And they weren't visited. And, I'm not really sure that Dr. Cimino, I appreciate your optimism, but I'm not really sure that those people are ever going to get, the kind of, whether you can sort of pick up and go back, what the kind of support that they would have had for all of those very devastating losses. And I think that will take on its own sort of sequelae. I think we're going to be dealing with that. And yes, I want to share, Reverend Hottinger, I see condolences on the loss of your brother, and condolences on the loss of your brother, and thanks really for the whole community on your family's openness, because there is such a growing incidence of suicide, and we hardly understand it. We really don't understand it from a public health perspective. And every time someone like you is courageous enough to talk about it, you're going to save lives. You're going to save lives. So I think that this issue of kind of disenfranchised grief, unexpressed grief, these are things that are going to go on. And another thing that relates to is it also called attention to the horrible situation for people in congregant living facilities in our country. Really just the truly, look, let's face it, a lot of people died there under circumstances that were completely beyond their control and their family's control, and had a lot to do with standards of care and quality of care and patient rights in those institutions. And that's also something that has to get dealt with, right? A lot of people I know where I live, we're seeing many, many more people wanting to age in place and age at home even than ever before. But because of, people are not adequately compensated for those jobs. We don't pay attention to the fact that caregivers are simply not given a living wage. And so it's been part of that great resignation, so to speak, people leaving that field. And there's a tremendous crisis of people who don't feel safe in a congregate living facility, those facilities having very inadequate staffing, and also difficulty keeping people safe at home.
Yeah, I think that's a really good point. We do have another question from our guest, Dr. Like, and I think it's a really great, so to all of the panelists, in your ongoing work with diverse spiritual communities and denominations, do you see any efforts taking place relating to helping individuals and families who are living with long COVID and its various psychosocial sequelae?
Quite honestly, no. That's a great question. I have not seen it in person. I am in touch with patients who are dealing with this, and I think this is maybe going to be put in one of those categories with people like Rabbi Schoenfeld was talking about, who have mental health concerns, who struggle with long-term debilitating illness. Making space in our faith religious communities to because part of the problem. So I have one close work colleague who has long COVID. She was a young nurse. She will probably never work again, or at least not in the. I mean, she's been out now for 2 years. She looks fine on the outside, fine, and so it's that dealing with people who like, why aren't you back to work, and why you can function only 2 hours a day. What's wrong with you? You seemed perfectly healthy before. So destigmatizing and accepting and developing ministries and outreach to people who are really devastated for the long haul. And there's so much we still don't know about the impact.
Yeah, I agree with I echo everything you said. I don't think we're dealing with it. Maybe part of that is also because, people are still not getting together in sort of customary kinds of ways. So folks who are struggling with long COVID, like so much else in the pandemic, are largely struggling alone, right? They're home and by themselves, and folks aren't getting together with their friends. They're not going, to our houses of worship in the same way. But you raise a lot of important points, including whether there will be stigma and what we can do proactively to, avoid stigma to people who have what will become, a disability, a long-term disability for some people.
Yeah, I agree definitely with the others, as far as especially congregations when they meet may just want to try to emphasize, the positive, and forget about those people who are still suffering. So that will be a definite challenge. And I wish I don't really have a part in this research, but it's something that should definitely be looked at. These people that are still going to be suffering down the road.
Yeah, so I do want to start wrapping up because it is 1 o'clock, but I just kind of have one final broad question for all of our speakers, which is, where do you see us going from here? And kind of what strategies can we engage in, or what strategies have you seen that can be effective in providing that needed emotional and spiritual support that people need right now?
I probably won't have that much to say, but as far as just, as you mentioned, keeping in mind that people are still suffering from this, and it's a long-term type of, crisis that's not going to be resolved, just when the public health measures are lifted. But I was kind of interested in, I was looking at an article on the Black Church and how they have dealt with COVID. And, it's just interesting because we always associate that with so much interaction and, conviviality in the congregation, and how they're dealing with that. And I find, kind of how it applies to a lot of congregations, how they're speaking about multi-site. And it used to be only the big mega churches were considered multi-site, that had, a different location for their different congregations. But now even a smaller church is going to be multi-site, in the fact that there will be the in-person congregation, and then there'll be the virtual one, and how they've come to deal with that. And so, one Black pastor said that even at a denominational convention, they would only reach a certain amount of people. Now that it's online, so many more people are, you can reach many more. So that's kind of putting a good face on this, that, more people can be reached with encouragement, with prayer requests. But, the question is, how can that translate into, in-person care, which is so important for, for illness and for just mental health, mental health functionality. And so, that's going to be the big question. How are they going to balance this, this multi-site type of congregations to pivot over to help people in person. Okay.
I'm just going to add very quickly the one thought, sort of circling back. I think that we really need more integration of the faith community with the health and public health communities, and very much need the health and public health communities to come to understand in very concrete, basic ways how this sector can help them reach people. I think we need, frankly, Medicaid demonstration projects that do more to integrate health institutions with their faith institutions on the ground. I think that could have a lot of impact, especially in terms of social determinants of health and addressing those. And I also think on the sort of both mental health and social health levels, that we really need to do as much very practical training as possible, so that faith leaders, and I want to say community leaders, because I don't like to bifurcate between faith and no faith, right? Let's call them people of good spirit and goodwill, have basic training on messaging, so that wherever they're reaching people, in person, online, they're giving messages that help people go back to places where they can get help and support and get validation for all the difficult experiences and feelings they're going through.
Yeah, I would add on to that what Rabbi Schoenfeld just said. The religiously, culturally, spiritually specific approach, I think, from the public health sector, and having religious communities partner with public health, with other healthcare institutions, is key. We were able to begin to do that 2 years ago with this East African organization based out of Minneapolis. They actually approached us and they said, you know, we see the need. We don't think your healthcare system understands the resources that we have within the Muslim community, or actually throughout Minnesota. Why are you paying so little attention to these incredible networks? And to understand that when people of our culture, who are part of our immigrant community, approach the healthcare system, our religiosity is really at the top of the list of how we identify. I mean, that is shifting as newer generations come in, but it's been key. And the second thing I would say, I'll put my trauma-informed hat back on, is for faith communities to really take that broader and deeper perspective about the impact of collective trauma, historical trauma. Of course, I think we have a lot to learn from the Jewish community on this, as well as American Indian and African American communities, and to go then deeper in our own resourcing. You know, we have resources in our faith traditions to help people through crisis, to help them make meaning out of suffering, to help them metabolize, all the grief to get through. I was trained in a very individualistic model, kind of religiosity, spiritual care, back in the kind of 80s and 90s, and that has just been thrown out the window right now. And so getting much more communal and collective, and thinking through history, how can I connect with all those traditions that have so much to teach me as an individual provider and as a system leader, and getting humble about how I do that. So that's kind of my 2 cents. So thank you for great question.
Thank you so much for sharing, everyone. And thank you so much for being here today. I just want to say, I know COVID has posed a lot of challenges, but I also think it offers an opportunity to kind of reevaluate these systems and structures we have in place, and think about ways and be creative and be innovative for ways that we can engage with each other, engage with people, engage with our religious communities. So yeah, again, thank you so much for joining us today. I will open it up briefly to questions. If any of the participants have any questions for any of the panelists, but now would be the time to ask them. All right, well, if we don't have any questions, then we can wrap up. I just want to say thank you, everyone, for joining us today and making the time in your schedule to be with us. I think this was a really great conversation. I know I definitely learned a lot. We will be sharing resources in a follow-up email to all of the registrants for today's webinar, and we'll also share them with the panelists, and we can include the things that people shared in the chat today as well. So that will just include some of the resources that were mentioned by the speakers. It will include some of the publications the speakers have shared with me. And yes, so that will be made available to everyone who participated today. And I do want to remind everyone that this is a conscientious care series. So our next session will be held on March 25th from 12 to 1. So kind of during your lunch break if you have the time. And it will focus on religion and mental health. And we'll be talking about different ways religions understand and respond to mental health issues, how that compares to conventional treatments and kind of perspectives, and is spiritual treatment of mental health issues more effective than other techniques, and how can religious communities support followers who suffer from mental health issues? So that will be our topic for next time. Again, thank you, Reverend Hottinger, Rabbi Schoenfeld, and Dr. Cimino. Thank you so much for sharing your experiences and perspectives today.
Thank you. It's great to be here.
Thank you.
Thank you.